Hi everybody, welcome to Dr. Manny's YouTube Learn Shops. This is hemodynamic monitoring and this is part 1 where we look at non-invasive hemodynamic monitoring. The purpose of this Learn Shop, apart from being for you nurses and other healthcare professionals, it's for those of you who look after non-invasive hemodynamic monitoring patients. And this will just review some of the fundamentals that in my opinion pertain to non-invasive hemodynamic monitoring practices. And they can identify cardiac output issues without being invasive. The learning objectives are, we're going to look at your pre-knowledge review, look at the vascular system, the cardiac cycle, cardiac output, look at tissue perfusion factors, and then non-invasive hemodynamic parameters that I think are important, and review some cases. Okay, let's see what you know or remember. Okay, which of the following are products of cardiac output? Heart rate, stroke volume, preload, or all of the above? The correct answer is all of the above. The cardiac cycle consists of which of the following? Systole, diastole, isovolumetric contraction, or is it all of the above? The correct answer is all of them. The diacritic notch on the arterial pressure waveform represents which of the following physiological events? The aortic valve is open, the mitral valve is closed, the aortic valve is closed, or the mitral valve is open. Which one? The correct answer is the aortic valve is closed. Stroke volume is best explained by which of the following statements? It's the amount of blood ejected with each heartbeat. It's the product of cardiac output divided by heart rate. Is determined by heart rate, preload, afterload, and contractility, or is it all of them? The correct answer is it's all of them. The sympathetic nervous system, does it decrease the heart rate, decrease speed of conduction of the SA node, sinoatrial node? Does it increase contractility of the myocardium, or doesn't it do any of them? None of the above. The correct answer is it increases contractility of the myocardium. Question 6. Which of the following products create and affect afterload? Is it the blood volume, the circulating blood volume? Is it the systemic vascular resistance? Is it the viscosity of the blood? Or is it all of the above that can affect afterload? They can all affect afterload, and there are more, as you'll see. Which of the following pertain to the jugular venous pulse or the jugular venous pressure? It's normally less than 3 centimeters in height. It's found in the neck. It provides data about blood volume, or does it indicate everything, all of the above? The answer is all of the above. Question 10. Which of the following statements is related to urine output? In order to have a urine output, you require a normal systolic blood pressure. It requires a normal renal blood pressure. It requires a normal glomerular filtration rate. Or is it all of the above? The correct answer is it is all of the above. Good, let's move on. Now let's review the cardiovascular system. Now the cardiovascular system, the human cardiovascular system, is responsible for conveying blood through vessels to and from all parts of the body, and the blood carries nutrients and oxygen to the tissues, and also removes carbon dioxide and other waste products. It's considered to be a closed system that is tubular, in which blood is propelled by the heart. The heart is the pump. You've got arteries. What are arteries? Arteries are blood vessels that transport oxygenated blood away from the heart to the tissues, except for the pulmonary arteries. And they carry blood to the lungs for oxygenation. And this blood is deoxygenated. Arteries are also resistance vessels that deliver oxygen and nutrients to the tissues from the heart. Major types of arteries include the elastic arteries, which can be the aorta, conducting arteries like the subclavian arteries, or muscular arteries such as the brachial arteries. Arteries have got three layers. You can have the tunica externa, the tunica media, and the tunica intima. Externa outside, media middle, intima inside. And arteries are responsible and contain 15% of total blood volume under normal circumstances. Then you've got veins. Veins are capacitants, which means they store. Vessels that transport deoxygenated blood from the tissues to the heart, except for the pulmonary veins, which transport oxygenated blood from the lungs to the left atrium of the heart. Major types of veins include the deep veins, which can be femoral, superficial veins, which can include saphenous, and the pulmonary veins. They also have three layers. You've got the externa again, outside. You've got the media again in the middle, and you've got the intima, which is inside. They contain 70% of total blood volume. Then you've got capillaries. Now, capillaries are the smallest and most numerous of all the blood vessels. They form the connection between the arteries and the veins. Their primary function is to remove metabolites, waste products, provide nutrients, oxygen, hormones from and to the cells of the tissues. As far as their thickness, they're only 1 cell thick. You've got three major types: continuous, fenestrated, and sinusoidal. And they're so small that one red blood cell can only go through them at a time. And capillaries contain approximately 5% of the total circulating blood volume under normal circumstances. Then you've got the cardiac cycle, which we've reviewed in other courses. The cardiac cycle basically is the performance of the human heart from the beginning of one heartbeat to the beginning of the next heartbeat. Essentially, it consists of two phases, one during which the heart muscle relaxes and refills with blood. This is called diastole. In Latin, diastole means to dilate, following which there's a period of contraction, energetic contraction, and pumping of the blood by the heart. This is called systole. Systole in Latin actually means to contract. Systole provides emptying of the blood from the heart. Diastole provides the phase of filling. Now let's look at it in a little bit more detail, because as we go through this course, especially when we look at invasive hemodynamic monitoring, we need to understand these concepts. You've got ventricular diastole, which can be early. And what occurs during this phase is basically isovolumetric relaxation, passive atrial filling, and all the heart valves are closed. The atrioventricular valves are closed and the semilunar valves are closed. Then you've got ventricular diastole mid. And what occurs during this phase is the tricuspid valve opens and the mitral valve opens and passive ventricular filling occurs. And passive ventricular filling consists of about 70%. So 70% of ventricular filling right and left occurs passively. The next phase then is ventricular diastole, which is late. And the events that occur during this phase are that the atria contract. And when they contract, this is referred to as active ventricular filling, to make sure that the ventricles are nice and full of blood, To add to the 70%, you get an additional 30% from active ventricular filling caused by the atria contracting. This is also referred to as the atrial kick, if you'd like to use lay terminology. And this provides an end diastolic volume within the ventricles, which means how much blood is in the ventricles at the end of filling, diastole. Then you've got ventricular systole. And as I said, systole is emptying, systole is contraction. And the events that occur during ventricular systole early are isovolumetric contraction. And this is where the heart starts to put on pressure to itself to try and open the aortic valve in particular and the pulmonic valve. And it's attempting to open the semilunar aortic and pulmonic valves, which requires a lot of effort. All the heart valves are still closed. The heart is trying to create pressure, isovolumetric pressure, to try and open these valves. And this is the hardest phase for the heart to perform. It's a lot of work. Then you've got ventricular systole, which is rapid. And the events that occur is, wow, the aortic valve has now suddenly opened, the pulmonic valve is also opened, and you've got active ventricular emptying. And about 75% of blood is ejected from the heart during this phase. Then you've got ventricular systole, which is a little bit slower. And the events that occur here are that the aortic valve and pulmonic valves are both open. You've still got active ventricular emptying, but it's a little bit slower. And whatever remains in the ventricles at the end of this phase is referred to as the end systolic volume, because the heart isn't ever empty of blood, it still has blood in it. I mean, if it was empty, it would be full of air, and that would result in a problem. Now let's review cardiac output. Cardiac output is a term that describes the amount of blood that your heart pumps with each beat every minute. The cardiac output, medically calculated, is by multiplying the stroke volume multiplied by the heart rate. So the cardiac output equation then is cardiac output equals stroke volume by the heart rate. And approximate ranges are as follows. They're just approximates. The infant, about 150 to 200 mils per kg per minute. Child, 100 to 150 mils per kg per minute. And an adult, approximately 80 to 100 mils per kg per minute. What are some of the determinants of cardiac output? Well, heart rate is one of them. Preload is another. Afterload is another. Contractility and stroke volume. I like to include atrial and ventricular synchrony, which basically means that the heart is in synchrony with each chamber. So atrial ventricular synchrony basically means that the atria contract first, emptying the blood from the atria into the ventricles. This is the atrial kick or atrial contraction. And this then results in the ventricles being filled actively. And when they're filled actively, the ventricles are full of blood to about 100% capacity. This is atrial and ventricular synchrony. So, in order to have cardiac output, you require heart rate, preload, afterload, contractility, stroke volume, and atrial and ventricular synchrony. So what's heart rate then? Heart rate is the speed of the heartbeat measured by the number of contractions of the heart per minute. Approximate rates, just approximate rates, adult 60 to 100 beats per minute, child 80 to 120 beats per minute, infant 100 to 150 beats per minute. Bradycardia may decrease or increase cardiac output, depends on what's caused it. Tachycardia may also decrease or increase cardiac output, depends on what's caused it. Abnormal situations decrease, normal situations may increase. What's stroke volume then? Stroke volume. It's the volume of blood in milliliters ejected from each ventricle due to the contraction of the heart muscle. which compresses these ventricles to empty blood, to eject it. Stroke volume is the difference between the end diastolic volume, end of filling, and the end systolic volume, end of emptying. So stroke volume formula or equation then is stroke volume equals cardiac output divided by the heart rate. And typically in an adult it's about 70 to 100 mils per beat per minute. In a pediatric, well, this will vary depending on age. What's preload then? Preload. This is the initial stretching of the cardiac myocytes prior to contraction. Well, really, it's related to ventricular filling, and from my perspective, to make it simpler, it's the amount of blood in the heart before emptying, reflecting the end diastolic volume. It's the volume of blood at the end of cardiac filling, diastole. And typically it's about 70 to 120 mils, plus or minus about 25 mils. What's afterload then? Afterload, after the load. After it's been ejected. This is the force or load against which the heart has to contract to eject blood from the ventricles in systole. And from my perspective, it's anything that affects blood from being ejected from the heart. Typically, it's related to arterial pressure. So therefore, blood pressure, because of vasoconstriction or vasodilation. If you've got vasoconstriction, it's harder for the heart to empty, increased systemic vascular resistance. If you've got vasodilation, it may be easier for the heart to eject blood from the heart. Depends on what's caused the vasodilation. So therefore, afterload is increased when the arterial pressure and the systemic vascular resistance are high, vasoconstriction. And this will result in an increased end systolic volume, and this will decrease your stroke volume because it's harder for the heart to empty blood out of the ventricles. This can occur in the pulmonary circulation as well. You can have pulmonary hypertension, pulmonary vasoconstriction, which will decrease blood going to the lungs. In the systemic circulation, you can have vasoconstriction, increased systemic vascular resistance, and this will decrease ejection of the blood, stroke volume. Then you've got contractility, which is often referred to as inotropy, or being inotropic. And this is defined as the tension developed and the velocity of shortening or the strength of contraction of myocardial fibers at a given preload or afterload. And basically it just reflects or represents muscle strength in the ejection fraction. So increasing afterload causes an increase in ventricular contractility or inotropy. And this is due to the activation of the sympathetic nervous system catecholamines such as epinephrine and norepinephrine. So basically what it means is, if the heart has to work harder, it will work harder. It will work harder and contract more forcefully, but only up to a given point. If it has to contract or shorten its myocardial fibers too far, it will probably result in heart failure. But contractility is basically inotropy, how effective the heart contracts, because you can have positive inotropy, which is strong, and you can have negative inotropy, which is weak. Then you've got the ejection fraction. What's the ejection fraction? Well, just think of it, ejection, what you're getting rid of. It's a percentage. So ejection fraction is the percentage of the preload or end diastolic volume that's ejected with each contraction of the heartbeat, your stroke volume. And normal is typically around about 0.55, 55%, to 0.7, 70%. But this can only be measured with more sophisticated tools, such as possibly during echocardiography. Otherwise, it's an estimation. Then you've got synchrony, which I spoke about before. And synchrony is the atria and the ventricles working together. I mean, if they don't work together, like in atrioventricular dyssynchrony, junctional rhythms, ventricular rhythms, even atrial fibrillation, atrial flutter, the atria and the ventricles are not working together. When you have a premature ventricular contraction, complex, ectopic, atria and ventricles are not working together. The ventricles are working first. So atrioventricular synchrony is coordination between the electrical activation of the atria and the ventricles and mechanical contraction. This is AV synchrony. An optimal AV synchrony can increase the cardiac output by about 25 to 30%. If you don't have your atrial kick, atrial contraction, atrial systole, as happens in atrial fibrillation, you can lose 25 to 30% of your cardiac output. Now let's review some of the non-invasive hemodynamic parameters. I've just listed them as such: skin colour, skin temperature, muscle strength, pulse oximetry, respirations, blood pressure, ECG monitoring, the capillary refill time, the level of consciousness, the jugular venous pulse or pressure, and urine output. And these are just some of them, more common ones. So, remember, the skin is the largest body organ. It's a non-invasive hemodynamic parameter from my perspective, because the skin requires 10% of cardiac output for normal perfusion, which is about 500 mils per minute. So therefore, if anything happens to cardiac output, the skin as a non-vital organ will be affected immediately. And it informs you about tissue perfusion. Under normal circumstances, the skin is pink and warm, vasodilation. Under abnormal circumstances, where you have a problem with cardiac output, the skin will become vasoconstricted, cold or cool, pale and clammy. When you look at skin temperature, well, skin temperature is the temperature of the outermost surface of the body. Normal human skin temperature varies about 33.5 to about 36.9 degrees centigrade. So normal human skin is typically warm and dry. Cool skin depends on why, maybe ambience of the temperature. However, cool skin may indicate a low cardiac output and poor tissue perfusion, because the skin is one of the first organs to be affected by low cardiac output. It becomes vasoconstricted, sympathetic nervous system response, compensatory mechanism, and it may become cool, clammy, sympathetic stimulation, and pale. The muscular system is a good indicator as well. Muscular system provides a person with strength, coordination, energy and warmth, and a normal body temperature, because the muscular system is responsible for generating heat. Stresses such as fatigue and hypothermia could indicate that you have a low cardiac output, and therefore should be considered as a non-invasive indicator of hemodynamics. Remember, this system requires 13% of cardiac output, which is approximately 650 mils per minute for normal cardiac function, if you have a cardiac output typically at around about 5 litres per minute in an adult. So if you lose cardiac output to the muscles, you may become weak. You may experience fatigue. It's a good indicator. Then you've got pulses. Pulses are sensations of stroke volume felt over an artery. And we feel these as blood moves through the artery. Whenever the heart beats, stroke volume, ejection, you feel a pulse. A normal pulse rate coincides with the heart rate, typically. But heart rate and pulse are not the same thing. You can have what's called a pulse deficit, which we're not going to explain at this different, but basically it means you could have a heart rate, for example, of 80 beats per minute and only have a pulse rate of about 75 beats per minute. Pulses can be central, such as carotid femoral and brachial pulses, or peripheral, such as the radial, popliteal, or dorsalis pedis. Then you've got pulse oximetry, and we're going to focus on the saturation in particular. And pulse oximetry is a non-invasive method for monitoring a patient's or person's oxygen saturation and their pulse. Peripheral oxygen saturation, SpO2, the readings are typically within 2% of accuracy of the more desirable reading of an arterial saturation, which again isn't really easily accessible because you need to have a blood gas taken in order to perform analysis. So a normal arterial blood gas oxygen level, for example, is 80 to 100 millimeters of mercury at room temperature at sea level, and then the SpO2 is typically related to that, which is about 95 to about 100%. Then you've got respirations in the lungs, and respirations are a non-invasive hemodynamic parameter, believe me, because the lungs only require 2% of cardiac output, which is about 100 mils per minute. And this is for lung cellular requirements. But remember that the lungs utilise 100% of cardiac output, which can be more than 5,000 mils per minute, in order for reoxygenation, getting rid of CO2, for vital gas exchange. Respirations in the literature are the first sign, the first vital sign to change for compensation to increase oxygen delivery to the tissues if there's a problem with hemodynamics. So basically what that means is if you've got a low cardiac output for any reason, the brain will be stimulated automatically through the medulla oblongata, and the respirations will be the first sign to change to increase oxygen delivery to the tissue. So the respiratory rate typically in an infant is approximately 40 to 60 breaths per minute, child 20 to 30 breaths per minute, adult 10 to 15 breaths per minute. Some of the academics, a colleague that I used to work with, Ronaldo Bellomo, an intensive care physician, he wrote a paper, have a look at it in the literature. It's called The Respiratory Rate, the Neglected Vital Sign. It's the first vital sign to change if there's a problem with cardiac output. Then you've got blood pressure, and we're looking at non-invasive, so we're looking about a cuff. Now it's important to remember that blood pressure is the pressure of circulating blood against the walls of arteries, blood vessels, especially in the large arteries. The systolic blood pressure is the pressure in the arteries during contraction of the heart, which we said was systole. The diastolic pressure is the pressure in the arteries when the heart muscle is between beats. And a normal systolic blood pressure in typically, remember typically, there's no normally here, but typically from 1 to 10 years of age is the formula 90 plus age times 2. If you're older than 10, you're considered probably to be an adult, and your blood pressure will typically or should be around about 120 on 80. A non-invasive measurement for blood pressure uses a cuff. Make sure that the cuff is the correct size and placed correctly on the limb. Otherwise, you may get erroneous readings. Then you've got the ECG. The ECG, cardiac monitoring of the heart. And this is a non-invasive tool that ensures normal cardiac function. The heart requires approximately 5% of cardiac output, which is about 250 mils per minute. Cardiac ECG monitoring is a non-invasive measurement tool. It provides information about the heart rate and the rhythm, and whether it's regular or not. In an infant, typically 100 to 150 beats per minute. In a child, 80 to 120 beats per minute. In an adult, 60 to 100 beats per minute. Bradycardia and tachycardia may indicate an issue related to cardiac output. Then you've got the capillary refill time. Now, capillary refill time is often misunderstood. This is the time it takes for the capillary bed, as in the fingers, which is peripheral, or in the chest on the sternum, or over the clavicle, which is central, to regain colour after pressure has been applied for about 5 seconds, which causes blanching or whitening of the skin. Essentially what you've done, you've pushed blood out of the capillaries. Now, the normal capillary refill time is about 1 to 2 seconds, which is consistent with normal blood volume and perfusion. A prolonged capillary refill time, more than 2 seconds, may indicate a low cardiac output and poor tissue perfusion. But look, if you're in a cold room, it may be erroneous. If you are in shock, your capillary refill time will probably be prolonged centrally by more than 5 seconds. And this is due to shock due to vasoconstriction. In the periphery, it may be longer than that. I think level of consciousness is a good indicator as a non-invasive hemodynamic parameter as to tissue perfusion. And this indicates a patient's level of arousal and awareness, but how you assess the level of consciousness and document it can be subjective. However, remember, the brain is a vital organ that requires 15% of cardiac output under normal circumstances, which is approximately 750 mils per minute. Therefore, I consider it a non-invasive indicator of effective cardiac output. So normally, this ensures that a person is alert and conscious and has, we'll just use one tool, a normal Glasgow Coma scale. Level of consciousness as an indicator of cardiac output. Mentation. Then you've got the jugular venous pulse or pressure, if you want to consider it as that. And the JVP is the vertical distance between the highest point at which the pulsation of the jugular vein can be seen. You can see it. You can't feel it because it's not an arterial pulse. It's a venous pulse. So you can only really observe it, and typically it can be observed at the sternal angle. Now, the normal JVP is typically less than 3 to 4 centimeters above the sternal angle, and then it can be correlated to the atrium, which is about 6 to 8 centimeters above the right atrium. Typically, it's measured with the patient sitting at 45 degrees. But it can be taken at any measurement, but if you lay them down more than 45 degrees, you probably won't see the top of the pulsation. So typically 45 degrees is a fairly standard position that you can review it in. And it can be elevated. Typically you don't normally see it. But if you see it, then it can be elevated. Now the kidneys, they're fantastic. And urine output is a very good indicator of normal cardiac output. And we're looking at all these parameters in the light of a cardiac output of about 5 litres per minute. And this provides a normal blood pressure and a normal renal perfusion, which results in normal renal perfusion and a normal glomerular filtration rate. But in order to get normal renal perfusion and a normal glomerular filtration rate, you require 25% of cardiac output. And that's about 1,250 mils per minute out of a cardiac output of about 5 litres per minute, 5,000 mils. And normal urine output in an adult is approximately 0.5 to 1 mil per kg in adults and about 1 to 2 mils per kg in pediatrics, with normal, typical oral intake. When the cardiac output is low then, because of hypotension, then there's less renal perfusion and a lower glomerular filtration rate, and therefore you produce less urine. So urine output is a vital non-invasive indicator of hemodynamics. It's always probably better if you're in a clinical area, if you want to use this as a tool, to have a urinary catheter in. Okay? Because waiting for a patient to pass urine may not be as accurate. So look, let's do some revision. You've got a 65-year-old male with a past history of being a smoker and having high low-density lipoproteins, cholesterol. He complains of central chest pain. He's anxious and alert, but orientated. He's got cold, pale, clammy skin. His capillary refill time is more than 5 seconds. Heart rate, 125 beats per minute, and he's into sinus tachycardia. His pulse is rapid and weak, and he's hypotensive with a blood pressure of 80 on 60. His JVP is elevated at 8 centimetres, and his respiratory rate is tachypneic at 32 breaths per minute. So what do you think? What do these non-invasive parameters tell you? Or probably tell you is probably better? Well, he probably has angina and heart failure, which was represented by hypotension with sympathetic nervous system compensation or stimulation. Case 2. You've got a 35-year-old female. She suddenly develops right-sided chest pain after a really severe, strenuous coughing episode. She appears to be short of breath and she's complaining of difficulty breathing. She's confused and really anxious. Her skin, she's cyanized and it's cool. Her capillary refill time is 5 seconds. Heart rate, 120 beats per minute. A sinus tachycardia, she's hypotensive, 70 on 60. Her pulse rate is rapid and it feels very weak. Her JVP is 7 centimetres and her respirations are tachypneic at 42 breaths per minute. What could be a probable reason why she's demonstrating all these things with her non-invasive parameters for measurement? Well, she probably has developed a tension pneumothorax, which indicated by right heart failure. She's hypotensive and she has sympathetic nervous system compensation. What about case 3? This is a 25-year-old male, 25. However, he's got a family history of high, low-density lipoproteins, triglycerides, he's hypercholesterolemic. Suddenly he complained of chest pain, central, while jogging. He's really anxious, pale, sweaty, clammy. He's got a capillary refill time of more than 5 seconds and his heart rate is about 140 with a pulse that's rapid and weak. His ECG, when the paramedics come, indicates sinus tachycardia. He's hypotensive with a blood pressure of 60 on 50. His JVP is elevated at 9 and he's tachypneic with now respirations of 36 breaths per minute. So what do you think? Non-invasive hemodynamic parameters, what are they indicating to you? Well, probably he's having a myocardial infarction and is demonstrating a degree of heart failure and he's hypotensive with sympathetic nervous system stimulation or compensation. Our final case is a kid. She's 5 years old. She's had normal milestones, but one day, today, she suddenly becomes really dizzy. She's feeling faint and she's complaining of feeling beating in her chest, palpitations. She's anxious and really restless. She's cold, pale and clammy. Her capillary refill time isn't too bad at 4 seconds. Her heart rate, however, is about 180 to 200 beats per minute. Her pulse is really rapid and weak. Her ECG is really fast. Her blood pressure is acceptable at 90 on 60. Her JVP, she's a kid, is typically not visible. Respirations are about 38 breaths per minute. What are these non-invasive hemodynamic parameters potentially telling us? Well, they're telling us that she probably has a supraventricular tachycardia because she's possibly hypotensive with a low cardiac output, even though the blood pressure is acceptable for her age group. So, that's the end of part 1, non-invasive hemodynamic monitoring. Thanks again. Now, following this review, look, this is part 1, non-invasive. Go and have a look at review part 2, arterial, part 3, central venous, part 4, pulmonary artery pressure, part 5, cardiac outputs using thermodilution. See you next time, I hope. And look, if you think this Learn-shop is of any value, please pass it on to your colleagues. My objective is to provide education. That's all. I want it to be utilised. Thanks.